there's a problem there, and that problem is not that you guys don't have enough money, is that I think you guys are actually making a little bit too much money for what you exist to do in the world, you know?
Really excited for today's podcast episode. I have a good friend of mine, Josh. I've known him for a long time. We were medical assistants together at Rockwood Endocrinology, and both of us are currently in the same sort of phase of nursing school, but at two different nursing schools, right? He goes to WSU, ranked number 40 in the country. And on today's episode, we're going to be talking about trust in healthcare that patients have, and where do nurses kind of fit into it. All right, so Josh, we go back quite a long ways. Nobody in my audience knows who you are. You know, we worked as a medical assistant, I don't know how many years ago, in endocrinology. I know you're a nursing student at WSU. What else do you want folks to know about you before we get started?
I'm not the typical nursing student, I would say. Like, I never considered myself a nurse, or wanting to go into nursing up until, I want to say, the last couple years when I was pursuing PA school, and I decided to take the nurse practitioner route instead. So I never went into nursing like always wanting to be a nurse or anything like that. I wanted to be a PA first and foremost. So I kind of come at nursing from a little bit more of a prescriber mentality, and I'm also one of only like 3 or 4 guys in my class. So I'm also a male like you in a predominantly female-led field.
No way.
So, yeah, I know.
Yeah, you know, first of all, I know we have our things we want to talk about, but, you know, I won't say how recently, but recently I had this interview with this other individual. How is it coming from that perspective and not wanting to go into nursing, having the mindset of like originally wanting to do PA, being in nursing school? It was recently told to me that nursing and being a provider, whether it's an NP or PA, have almost nothing to do with each other, and nursing is a lot less. It's not STEM. It shouldn't be considered STEM, but being like any kind of provider is actual like STEM science. It's more, so there's like a different approach.
Definitely.
How is it? Have you had to like force yourself to just change the way you're thinking? Be like, oh, I'm not treating a disease, I'm treating a person. Like, how has that kind of been?
You know, it's a really good question, especially because WSU's approach to training nurses, it would confuse even a prescriber, like as somebody who's going through nurse practitioner school, because they're teaching us the physiology of diseases, they're teaching us the medicine, like they're teaching us so much of what like a nurse practitioner would go through in terms of like the background of disease and pharmacology, that you end up thinking, like, am I learning how to be a nurse, or am I learning is this like a pre-nurse practitioner program? Because all of the nursing that we learn is on the floor. It's in our clinical sites. It's like in our labs. And all of our lectures are about disease processes, mental health, pharmacology, and the science behind drugs. And it makes you feel ill-prepared to go into nursing, because you're learning all of this academic, all of the biomedical science without really understanding how it's going to be applied to your everyday job. And honestly, if this was like a pre-nurse practitioner program, this would make a lot of sense. But in terms of a nursing like classes, it really doesn't prepare you to be a nurse.
Yeah, I mean, I think a lot of nursing students feel the same way, because I think there's a lot of rigmarole and there's a lot of like difficulty that they need to introduce into programs. And everything's so competitive, everything's so difficult. Like, obviously, I know our nursing schools are both, like both of our schools are ranked very high in the country. I kind of wonder, because we take that same approach. Many test questions give a whole thing and then are like, you know, what disease process do you basically what is the diagnosis?
Yeah.
Straight up ask you, what is the diagnosis? What would you order? What would you anticipate order? And so,
Exactly. What would you anticipate ordering? And I do appreciate that approach because it allows you to anticipate what a provider should be ordering, which allows you to like catch errors. It allows you to anticipate what could go wrong with a patient. And don't get me wrong, like I absolutely love that side of things.
Yeah.
I mean, Lloyd, you and I being medical assistants while going through like nursing school, one of the biggest struggles I'm sure you faced, it's the same struggle I face every day in the urgent care, is I can't use my nursing skills as a medical assistant.
Right.
And so like, and so when I'm thinking about nursing, I'm like, how much of this am I even going to be able to apply to nursing practice? And then you realize, oh yeah, they're trying to get you to pass the NCLEX first and foremost. And they're very candid. They say, we're trying to get you to pass the NCLEX. You're going to learn how to be a nurse on the floor. And I think that does the hospitals a huge disservice because they're having to compensate with residency programs. And I just don't think that that's a good use of tuition dollars, you know?
Yeah. You know, again, I've thought that for a while. I don't know what the solution will be. I don't know that we're here to talk about that. I don't know that it'll change anytime soon, but I think, not even, I don't even think you're going to learn how to be a nurse on the floor during clinicals per se. Like over the course of a semester, you get, I don't know, for med surg, I got 10, 12-hour shifts. So I got to go to work 10 times. That doesn't prepare you. On top of that, you get put with nurses that didn't ask you to be with them. And you shouldn't feel entitled to any kind of experience. You shouldn't feel entitled that person should welcome you with open arms, although they probably should. Yeah. And most importantly, a really important part of nursing school, which is learning how to be a nurse on the floor, is outsourced by that school you'd paid thousands of dollars to people that aren't getting paid to do that don't want you there. It's a really weird thing.
Yeah, it's a really strange dynamic while the actual nursing school is attempting to get you to pass the NCLEX. And I think that this kind of ties into what I was hoping that we'd talk about, which is like kind of this trust issue in medicine. And I mean, nursing schools have their fair share of like trust issues because they're not very forthright oftentimes with like how they're training you or why they're training you. But because prime example, we had this person come in who's trying to get us prepared for our final semester ATI exam, right? And they're giving this big presentation on what you can expect the ATI exam to look like. And then they conveniently skipped over a slide. And my buddy later on, he goes, wait, what was that slide they skipped? And she never returned to it. And it turns out in that slide, they say that if you don't pass this exam, you don't get to sit for the NCLEX. And that threw us all for a loop. We were like, why are they not telling us about this? I mean, it makes sense because they want to keep their NCLEX scores up. They want to make sure that their pass rates are up so that they can rank higher nationally, but also so that they can make sure that their students pass the NCLEX. So if you don't get to sit for the NCLEX because you're most likely not going to pass, then they can artificially inflate their numbers, whatever it is. And I think that just withholding that kind of information on something that's like, we've already invested tens of thousands of dollars into the program to know, and they just conveniently leave it out. It's like, what else are you not telling me about this program? I can't confirm 100%, but it was told to me also that in a selection process for some schools, I'm not sure if mine's included, that they have like racial metrics as well. So if you're, white, Asian, black, whatever it is, you rate higher or lower on the interview scale. And you have to make up for that in other areas on your interview in order to get into the school. And so just that lack of transparency is a problem, I would say. And if it's happening at the school level, one could only assume what's happening on the broader, the medical industry scale.
Yeah, or it's safe to understand why patients would assume that there's also another lack of transparency. And it's kind of crazy how much information you can get from somebody, from an organization, right? But they're still not being transparent with you, but you have no idea because they're giving you all this information. It's just transparency. How can you really assess transparency?
That's hard. I don't know if you've experienced this, but when you give like an immunization, like a Tdap, right? And you have to give that viz sheet to your patient. You go, hey, this is all the information on the viz on the vaccine, the risks, the benefits, what diseases that you might have that might disqualify you from getting the Tdap. Here's that information sheet, right? How many times did you actually have a patient go, I'm going to read through this whole thing and I'm going to make sure that I understand it 100% before you give me that vaccine? Like how many? I can't think of a single time that ever happened.
Not necessarily that. I have had a couple of people ask like questions about things that weren't on the paper because they wanted to, I work here in North Idaho. And so a lot of the patients that I see don't want to have anything to do with a Tdap shot. But when they're in a situation where they've just cut themselves open, and they're being told like, oh, you have like the chances of you getting tetanus is really low. But if you do get it, nobody's gonna like be able to guarantee your survival.
Yeah.
And chances are you're going to die. And then if that's enough to move them, they're like, well, I just want tetanus. I don't want the diphtheria or the pertussis. Does this have this? I want the immunoglobulin treatment for it. It's just basically yes, but the only time I saw it was they were trying to find some kind of justification for not going through with the vaccine for some reason. But yeah, nobody reads that. We have to hand it out federally. But it's the kind of thing that also you hand out the after visit summary that nobody reads, and then they say that you didn't tell them everything that you needed to tell them.
Yeah, I know. And so like even in our attempt to be transparent with some of the most basic things in medicine, patients don't even read, and we have kind of a cursory understanding of a lot of the like vaccine viz sheets that we hand out or whatever it is, because we have to do education for the patient whenever we discharge, and we really do need to have an understanding of the things that we're doing for patients. But even in our transparency, patients aren't taking full advantage and really understanding what they're being given. And I don't know if that's just time constraint, that's laziness, or whatever it is. But then imagine that on just the greater scale of the medical system as a whole. Like, how many different layers of bureaucracy do you have to go through in order to get an answer from someone up in the C-suite on why this bill is the way it is? And it's actually not the executive at the hospital who knows that. It's the billing department and the insurance company that they're talking to, and there's just so many hands in the medical pie that it's really extremely difficult to get answers. But that's why we trust a lot of the governing bodies like the CDC and the WHO and the nursing organizations and the who've done the research, who they have like an established history of authority to be able to give us a reasonable answer. But I think that so many of us, especially through COVID, patients lost so much of that trust because people running that system were caught on tape lying about some of the most fundamental things that we thought we understood about COVID.
Yeah, here's my confusion. So this is why I'm glad I had you on. Obviously, there's more distrust, by patients and, of the medical, quote unquote, medical establishment. And a lot of it has something to do with COVID. Now, help me to understand why that is, because obviously now there are a couple of things that I can point out that were obviously ridiculous that the public was being told. Was it just from that, or was it just the fact that because the situation was constantly evolving, right? Then what was true one week was actually found out to not be true the next week. It's kind of like the entire public was sold on a glass of wine a day or whatever is good for you, when in fact alcohol's poison for everybody all the time. Doesn't matter if you have a glass. Like, I'm sorry, it's not good for anybody. So it's like, and it's the same thing with diets. It's the same thing with so many things. So during COVID specifically, what was it that you think actually caused an accelerated distrust? Because I personally, maybe it's because I still work in the medical field.
Mm.
I don't feel like that I was super swayed to one direction of the other after COVID. I just don't feel like it's some huge difference.
Yeah. One of the hardest things about talking about these subjects on a podcast is that you want your responses to be clickable and quotable, but at the same time you want to like deliver the nuance that the subject matter like deserves. And so I'm going to try to distill what I think it was what kind of the primary drivers of the distrust during that time, and because you said you really didn't see a difference before or after, right? Like you didn't really see a huge difference.
I here's what I would say. After COVID happened, I don't have some different attitude towards healthcare than I did before. I think there were certain things that were told, like, the masks were being pushed without any real efficacy being shown. But at the same time, and then you have the people that were so-called quote unquote believers in science, right? Yeah. So they're wearing their mask while they're walking their dog outside by the river by themselves. It's just whatever kind of tomfoolery appeared to happen in the medical field. I looked at the people following both sides of the advice. Everybody looked moronic to me.
Yeah.
There's obviously a divide, which I don't get into politics on this, but there was a divide, and there's the medical community and a divide within the medical community, and everybody looked like morons to me.
Yeah. And I think that it's not the first time we've ever experienced a pandemic in U.S. history. It's not. Like, you look at the Spanish flu, you look at the HIV/AIDS epidemic. I mean, though it's not apples and oranges between those two events, the thing is that we've had public health crises in the past, and we've gone through a very large stretch of time between like the 1990s to today where, we haven't really experienced a whole lot of adversity. It's been relative peace on a scale that we haven't seen historically, minus the Middle East wars in the early 2000s and late 90s. And the problem is people started to this is just my opinion, but I think people started to forget that the state of the world isn't always, because they swung in two directions. The state of the world isn't always safety, so I don't have to be afraid of anything. And then there was other people who have a worldview that the state of the world is always chaos and fear, and I need to trust whoever whatever the government says. There's like these two different camps where whatever the authoritative bodies say, I need to listen to, and then the other camp that says don't trample on my freedoms. I'll take the risks as they come without regard of my fellow man. If I have a disease, then whatever, if they have a disease, that's, they can do what they want. But so you have this like intersection of these two different cultures in America where I think it just like kind of came to a head where the people who were naturally distrustful became more distrustful because they found out that that Dr. Anthony Fauci had lied under oath about where the virus came from, and he was also caught on tape saying just people will take the jab or they're going to get fired, so just make them fear that outcome. And then you had other people who trusted the government and wanted to do and almost like in a weird like power trip where they could get on the government side and almost like put their fellow man down and almost rat on them and stuff. And so it was a really strange cultural difference there, where you really got to see how politics and social rules kind of collided. And I think that that had always been there, but because we live in a time where politics is kind of interwoven into almost every single facet of life, and social media is in everybody's pocket at all hours of the day. People were able to make these, were able to get like these real time updates, and almost like it was almost like they were able to get these like software downloads from the government and change their opinions as they went, and there was just a whole lot of social turmoil during that time, and I don't think anybody knew what they were what was going on, because the information was changing constantly. And because the information was changing constantly, people didn't know who to believe or what to believe.
Well, and I don't remember too much as far as this, but I thought it was being made clear, like, hey, just so you know, we don't really know about this.
Yeah.
I mean, you go anywhere though. You go into your doctor's office, you go into the hospital. They do all these tests because they're like, well, I think it could be these three things, but there's this one thing that it's not likely to be that could kill you. So we're going to get an MRI, so that feeds into maybe distrust a little bit, but really, do you really want somebody coming in and saying, oh, based on just what you told me without looking at you or doing any tests, I know this is what you have. So here's this or here's that treatment and you can go now.
Yeah.
But what I'm saying is there's uncertainty built in to the medical profession, and there has been for a very long time, out of necessity. Do you not want that a little bit? But I think, you can interpret that uncertainty as, well, they don't know what they're talking about. Well, maybe if you stop watching Dr. House or Grey's Anatomy, right? Or even the Pit, the most like accurate television show out there, still there isn't really, it doesn't even show like the experience of like, oh, we think it's these three things. Let's get some tests and wait 5 hours for all this stuff to come back. And then we'll try to go into a different direction. And then when you find yourself working in a hospital, I hate to say this, I've been in a couple hospitals. There are people admitted because we don't yet know what's wrong with them.
Yeah.
And by the time they're discharged, they're just stable enough to discharge. We still have no idea what the hell happened to them or if it'll ever happen again. Like, oh, and then it's just like, oh, follow up with your primary. There's so much uncertainty. So I could see that being, do you think that that's where the distrust come from? Basically, has medicine itself actually done anything recently to earn distrust? I know there's historical, like unethical research a long time ago. I'm not talking about that.
Yeah.
That's ethical issues.
Yeah. I think one of the biggest issues that people find with medicine has to do with pharmaceuticals, because you have these pharmaceutical companies who have these sales guys who come in and, they wine and dine the doctors so that they can sell their particular medication. And anybody who is like 45 or older, 40 years old or older, is extremely familiar with the whole follow the money. It's like whoever has a financial interest in whatever industry, they're the ones who you need to be looking at. And I think that people have this just general understanding that there is money to be made on their condition. And it's because of that inherent truth that they think the whole of medicine is corrupt. And they don't want anything to do with medication. And they don't want anything to do with doctors because they think that they're bought out by the pharmaceutical company and that they're going to get kickbacks or whatever it is. And I think that is actually one of the primary driving factors in the distrust in medicine is simply the monetary interest that so many different parties have in your disease,
Okay, so there's a lot to unpack there. Yeah, I agree with that. And what I would challenge anybody to do that's so distrustful is go and volunteer or something and spend the day in a clinic, and you see what doctors or nurse practitioners or PAs are sitting there thinking, could we prescribe this med for them so that we can get some money? Because nobody does that. Nobody gives a dang.
Nope.
What drug they're
it doesn't matter what drug you're prescribing. Oftentimes the insurance company is going to say no, like 50% of the time. Actually, what is the statistic on that? How often does AI deny claims now? There's like a threshold where they have to meet.
Yeah, I don't know, because I don't know the AI numbers. I knew it was horrendous before. I mean, you and I worked, basically half of our job was doing prior authorizations, right? Oh, a type 1 diabetic has this insulin. We're going to not approve that. Why are you not approving that? And so here's where it lies. Yeah, the quote unquote good stuff can't get covered by people. So nobody's really paying for this anyway. These drugs, if they're really important to you, they'll basically give you a coupon where you can get like $1,000 prescription for like $50 a month or something.
Yeah.
these have always existed. And then that's ignoring, medication assistance programs, which nobody talks about that. But most importantly, what clinic or hospital even is making money hand over foot? I will argue no, none of them are. I will argue everybody that's making money in the healthcare industry is working for an insurance company. The insurance company is the number one reason why health costs have driven up. Let's not play any games.
So I actually wanted to touch on that because I think insurance is an extremely complicated discussion that I don't know if you and I are even qualified to discuss, only because insurance. So if you take insurance, right, and you look at if you like try to bring it down to like a really tiny sample population, so like 10 of us are pooling money together just in case one of us or 3 of us or 4 of us get hurt or whatever. So you and I are paying $100 into this theoretical insurance plan, and Joe Schmo over there gets hurt, and it's been we paid in, say, all of us collectively over a year paid in like $12,000 into the fund. And Joe Schmo wants a procedure that costs $20,000. We don't have enough, right? Whatever. But as you get more and more people into the insurance pool, things get a little strange. It's no longer primarily about how much money there is in the coffer, because now you have these people who are calculating to the day how likely you are to at what point you are to die, and so they can kind of calculate out into like decades and know how much somebody's like the risk versus benefit is to have them on the plan. And money isn't just sitting in some coffer not gaining interest. Like, the more money you can hold on to, the more interest it's able to accrue, and it's a really complicated system. But fundamentally, you have a bunch of money pooled from a bunch of different people who are able to help everybody else who's on the plan who's not who actually needs the funds for whatever diseases that they have or whatever conditions that they have. And the insurance company's goal is to just make sure that they can hold on to as much money as possible and not pay out as much as possible, and so that they can continue to exist as a business. However, when you have record revenues of billions of dollars at the end of the year, I think there's a problem there, and that problem is not that you guys don't have enough money, is that I think you guys are actually making a little bit too much money for what you exist to do in the world,
Well, obviously, yeah. I personally, I'm trying not to be biased, but I personally just think that insurance companies are horrible. And there's okay, everybody complains, right, about how much somebody's charging for a Tylenol, right? Well, the hospital charging $50 for a Tylenol. Okay, there's 2 things going against this.
Yeah.
This is why when somebody gets really mad and there seems to be a huge discussion among the normies, aka most patients online or in person, they're mad about the hospital charging $50 for a Tylenol, not insurance saying, whatever you bill us, we're only going to pay you 10%. Right. So originally the Tylenol was like 50 cents or whatever. And they're like, okay, so we'll pay you like 5 cents. That's not going to cut it. That's not going to pay the bills. Okay.
Yeah. Yeah.
So of course they're going to raise the cost for everything, because that's, the insurance companies aren't going to pay that. At the same time, and this is another kicker everybody ignores, these aren't insurance companies. Health insurance companies are not insurance. These companies are told, they are told what they have to cover by the government and by whatever contract, but you have to cover all of these things. What other insurance companies are told these are all the things that you have to cover 100% of the time, no matter who it is?
Yeah.
And so then the insurance company, right. Well, then the insurance companies have to pay out all this. So what do? They try, as best as they can, whatever's not legally required, to try not to pay that out, because they are being told you are going to pay this, times 10,000 things, right? For millions of people. And the hospitals are, raising their costs. So whenever someone like me right now, who doesn't have insurance for a short time, go to the hospital, the initial bill that you get might look shocking. Like, wait a second. Why did my ER visit cost $19,000 or whatever? I was there for like 9 hours. It didn't really cost that. And I'm not really going to have to pay that after I make a phone call and say, I'm going to pay you what the insurance company pays you. And there's a self-pay discount that they give you. They're not stupid. And, there's things that they can go off of your income. There's payment plans. I think my problem with the public distrust of organizations is that it's displaced anger and a lack of understanding of how the entire system works.
Exactly. Because nobody knows who to talk to. Like, nobody knows, at least the general public. And I would say that even healthcare staff have a hard time navigating healthcare. I have calls on a regular basis of people saying like, hey, I have this bill, I need you to talk to somebody about it. And so I'm just referring them off to medical billing, because I'm not the one who's coding their visit. I'm not the one who's trying to capture revenue from the insurance company for a particular visit. My sister does medical billing and coding, so she gives me an insight into that side of the world of medicine. And it's fascinating, because how do you even put a price tag on fixing a broken femur? How do you put a price tag on helping somebody recover from pneumonia? They've been on, a ventilator or whatever. Like, how do you price that? And the world, and so one of the things that I'm actually not a fan of with this current administration, even though I know I did vote for Trump, is that they want to have this price transparency thing in hospitals, where they have to, basically give like an itemized, like a menu in hospitals to patients about what something costs. And it's like, it's so much more complicated than that I think that it does the administration and the hospitals and healthcare in general and the patient a disservice to just have the prices up there, because those prices are subject to change, depending on what the insurance is willing to cover or not cover, or maybe it gets completely written off because the hospital's a non-for-profit and they're able to do that.
Well, I think obviously pricing those things can be complicated. There's the human factor, which is what you're probably referring to. Like, how do you price a person's life or their livelihood or quality of life?
Because one would say it's priceless, right? Like, it is so valuable that, like, I'm willing to pay anything, but nobody's willing to pay anything unless you're, desperate.
But that's the X factor. That's the only thing you can't put a price on, because believe it or not, obviously the value, quote unquote, of that person living or walking is not something you can put a price on and everybody be okay with it, right?
Yes.
However, there are a lot of things, most of your care in the hospital, you absolutely can put a price on. And this is what I've recently on here. My listeners will know I've gone after nurses complaining about their wages stagnating. Here's the thing.
Oh my gosh, I've got something to say about that.
Yeah, hospitals pay a crap ton of money for everything. Inflation's not just going up for you, Papa Bear, okay? It's going up for the hospital that's paying for the linen service to be done, the IV fluids, like those little flushes you put in your pocket. Those, they pay like at least a few dollars a piece for them. And you put 10 in your pocket, 2 or 3 times a day like it's nothing, and hundreds of nurses in the hospital are doing the same thing. You personally couldn't even afford the bill of just the saline flushes walking around the building, right? And so that costs money. The equipment costs money. The electricity bills of a hospital are like upwards of a couple $100,000 a month just for electricity and plumbing and the oxygen system.
It's probably more, but but for the sake of argument, yeah.
Right. Like, the point is, like, there are prices. Everybody that's working there has got to eat something.
And this is where the cost is. It's your wages.
It's people's wages, which we want to keep going up, right? And I'm wondering, and I know we'll get to it later, like where do nurses come in? At some point, the patient's going to be like, well, you're charging me all this money. You're making 50 blank dollars an hour to do this. You know how much I make, or you know how much I made in 1975, right? I'm wondering at some point, like the distrust with the money aspect is gonna, we're gonna be viewed negatively, because right now you have nurses making like $80 an hour going on strike, leaving hospitals, right? Yeah. Leaving hospitals.
It's abandonment of your duty. I just think it's awful.
But what were you going to say about
So there was we were having, during one of my classes, we were doing a Zoom class, talking about the social determinants of health and the economics of medicine, and we got to the point where one of the speakers asked us, like, what do you think is the solution to reducing the cost of medicine, or how do we reduce the cost of medicine? And I jokingly, like half jokingly, put inside the chat that I think that, if we care about patients so much, then I think we as nurses and doctors, we need to take pay cuts for the sake of our patients. And everybody inside that chat blew up at me, telling me that it's not the nurses' pay, it's not the doctors' pay, it's all the executives' pay. And I just had to laugh, because I understand that executives and CEOs are making way more than they used to, and probably more than they should, but I don't know how to put a value on that. But I do know for a fact that wages, that payroll, is the number one expense in medicine. And I think that if all of these nurses in nursing school are going to back up their what they're saying, is because what they want higher wages, and they want socialized medicine. And that's like, those are like two polar opposites. They are impossible for you to combine. And if they really cared, then if they really cared about the patient's financial situation, then they would take a pay cut. Or we would find a way to be better stewards of the resources we've been given, so that we and stop trying to increase social benefits, because because the hospitals are having to get reimbursed pennies on the dollar for Medicaid and Medicare these days, which is even further going to increase the financial strain on the hospital system, and then medicine as a whole.
Yeah, and it's not that I think that nursing is single-handedly causing increased prices by themselves. No. But there was a post about this recently, and I happened to put something in the comments, which Lord forbid I do that, right? Especially, I don't know how much you post or comment online, but if you don't have that RN yet, Josh, just so you know, everything you say is meaningless, by the way. Yes, that's true. Right? That's true. But I just had posted like, hey, at the time, I didn't do the math and say, yeah, they are stagnated if you look at adjusted for inflation, but you're still staying at a really good spot, and inflation's going up for the hospital too. And then they were just like, nursing doesn't contribute at all to the cost of healthcare. And I'm like, okay, not true. It's not a sole contributor, but if you pay the nurses higher, guess who else you have to pay higher? You have to pay everybody else higher, dude. You can't just be like, hey, guess what? Only nurses are getting a raise this year. No. Across the board, everybody is going to be getting raises when you start giving raises to nurses. I mean, CNAs where I'm at now are over $20 an hour. Before the COVID era, you were talking about like $14 an hour. So like in 5 years, you've gone up like almost $10 an hour for CNAs. Why? Because you have to keep paying. Yeah. It's just like a domino effect.
So if you had like if you got a $5,000 raise as a nurse, and your hospital employs 500 nurses, that means that if they wanted to be equal and give all of you guys raises, you'd be paying $2.5 million a year extra. And that money just doesn't come from nowhere.
Especially when, there was, my hospital I was at recently got in the news because they were about to, they couldn't agree with Regents Blue Cross on the amount that they were going to get reimbursed. And so they were on the cusp, days away from being like, hey, for the next year, nobody that has Regents is going to be able to come to this hospital to get reimbursed, which is a big deal.
Yeah, we're having the same problem.
Right. Well, you have to get reimbursed more when you're literally paying more for every single thing that walks through the building, including
and I think
people.
that people in medicine have never operated in a small business before, because I guarantee you, if all of the nurses out there who have an RN next to their name decided to go and work for a small business, they would start to contextualize their opinions about the economics of medicine a little differently.
Yeah. So it's easy to get complacent after a while of working for certain wages. And it's also like everybody at least most of the people in my class alone, I don't know about the folks you go to school with. I would assume they're pretty much the same, which is whenever they graduate, they're going to be making a life-changing amount of money.
Yes.
And guaranteed a job for like the rest of their life. Okay. You don't get that with almost anything else. But that same person, after 5 years on the job, right, will begin to get complacent and begin to get used to their lifestyle and be like, this is not enough money anymore. And they will start to demand more. It's just like human nature. I'm not blaming them or blaming nurses for being horrible people. But nursing specifically is like a lot higher than most other bachelor's degrees, at least in my area that I live in.
I think it's one of the highest bachelor degree programs there is.
And I don't talk about it a lot on my show because I don't want to sound weird and braggy, but I literally had, you remember when I was making good, I have a bachelor's degree in freaking cybersecurity, dude. Yeah. 12 IT certs. I'm a computer programmer. I literally got in the most highly technical job and complicated job I ever had that was local here. They were paying me $20 an hour for. I'm talking about stuff that you would see on TV. I was having to learn, right? I didn't work there for very long, right? Because labor, we forget, is a marketplace. If you don't like it, that's another thing. If you don't like it, get the hell out and go do something else. I bet you won't. There's all this talk about nurses leaving the profession every year, getting burned out. Where are these people going and still making money? That's what I want to know.
That's a really good question.
Or do they mean leaving bedside and going and working at a clinic making 40 an hour?
Because you can work for a pharmaceutical company doing sales. You can work in, you can be like a forensic nurse. I mean, you can be a triage nurse, whatever it is.
Yeah, there's a lot of, and I just had this discussion with someone else. There's a lot of jobs that, and I don't agree with this, that you can get because you have your RN that aren't nursing jobs, right? There's a lot of, like at my current organization, if you worked in clinics for 15 years, right? We've been a medical assistants for a long time. You should be able to, if you're actually excellent at your job and you're good with people, you should be able to maybe actually apply for a clinic manager position. Why do I need to have an RN and a bachelor's in nursing, by the way, to manage a clinic that I have worked at for 10 years and I understand the ins and outs of? You explain that to me, right? Nursing seems to be a gateway to a lot of high paying jobs, right? So if you go, like there's informatics, right? You are making more in nurse informatics than an IT person with 100 times the technical know-how of you. You are making more money than them because you have your RN. And a lot of people don't think about that. Like it kind of also hyperinflates other jobs that are administrative. And by the way, your job, you can kiss it goodbye probably in the next 5 years. If you're sitting there doing paperwork all day, because you hated bedside so much, you can expect your job to go bye-bye. And I will be one of the ones helping it go bye-bye, by the way.
Yeah, there's a regarding the whole AI, like because you said that you had a guest on who is trying to replace a lot of the paper pushers with AI. There's a famous quote, and I cannot remember who said it. It was somebody who was part of I think it was maybe Google, IBM. It was one of the big guys, but they were saying that a computer can never be placed into a managerial position because a computer cannot be held accountable. And I think that as time goes on, people are realizing, and I think especially because I think there was this big controversy where where a company was using, it was either I can't remember if it was Claude or some other large language model, but basically it deleted the entire database for a company. And then the AI just goes, oh yeah, my bad, my fault, whatever. And the company tried suing the company that was affected, tried suing the company that provided the large language model, but they said that they're basically when you signed the contract, you accepted liability for whatever outcome the AI provided you, and people are realizing that AI, you need to be able to hold somebody accountable, and I think that is part of the distrust in medicine, because you need to be able to hold somebody accountable. And in medicine, we are always pointing the finger. It's not my fault. It's his fault. It's not his fault. It's,
Oh yeah.
whatever.
Oh, yeah.
Like, the accountability train is endless in medicine. And I think AI would only further exacerbate that problem.
Yeah, no. So that's something that there's two things that and I don't mean to make this a whole thing about AI, but I think there's two main things that need to happen when these are implemented. One, patients need to have the ability to consent and opt out to any AI touching their health in any way, shape, or form, right? So you need to be able to, no matter what AI systems you implement as a hospital, you need to be able to have an off switch for individual patients that say, I absolutely don't want AI to have to do anything with my care. Why do patients have to consent for you to, take a mole off of them? But if I want AI to make all the decisions for me and handle your data, patients aren't even aware of the capabilities, let alone consenting for it, right?
Exactly. And it's like, how integrated is AI into medicine, where if you signed a consent form or rejected a consent form saying, you don't want AI involved in your care, right? And the doctor goes, oh crap, now I can't use AI charting. I can't use AI, my AI assistant. I can't, and so then the doctor comes in and goes, hey, I'm sorry, I can't treat you because you rejected this consent form, because everything I do now relies on AI.
Well, and here's the other issue. I don't know the background of the specific instance that you're talking about, but yes, they did sign the contract. So I guess you could argue that we just need to make contracts, a little bit, make companies a little bit more reliable. But something that I recently looked at was there was a hospital that had introduced a medication error kind of AI system integrated in with their version of a Pyxis, right? And for months they missed an anesthesiologist, or it was a CRNA that was, taking drugs, right? Well, here's the deal. It had this article was thousands of words, and buried somewhere in there, conveniently at the bottom, was this hospital system implemented this AI system at their hospital in its initial testing phases. This was not even a finished product.
Yeah.
So and when it comes to an AI system, okay, forget about AI. When you have people working for you, a person can easily, and it happens a lot in IT, right? It's some IT people's worst nightmare. I accidentally deleted the whole database. Well, guess what? You do not give a single person the authorization to delete a database. It is simple IT. It is called the CIA triad.
Yeah.
And this is known by everybody in IT. So at the end of the day, I'm sorry, even in that case, that system shouldn't have been given permission to do that. And what I mean by replacing jobs is...
So there was... I was able to find the article, and it was Claude. It was Anthropic's Claude Opus 4.6 model. Basically... after it deleted the Pocket OS's database, it said that it confessed that it violated every principle it was given. So even with guardrails in place, the AI broke the guardrail and then deleted the database.
Right. And what I'm trying to draw a parallel. There's two different things that I'll make a point of. One, there's a parallel to you also hiring an employee, pissing off that employee, and them deleting everything.
True.
Right? There are guardrails in place. Right?
You can then prosecute that person, though.
Right. But who's ultimately responsible for that person's data being leaked to the dark web? The hospital is held responsible. You can fire the person and maybe press charges, but guess what? You are responsible for your employees, right?
Yes.
The second part is those jobs, a lot of these clerical jobs, I'm not talking about management, maybe some middle level management you could argue. I'm talking about the people that do all of their work on a computer. These are the jobs that I'm talking about. And by the way,
radiology,
they don't need AI. They don't need AI to be replaced. I can replace jobs with my computer that's sitting on my lap right now. And I've been paid to do it. I have been paid to automate entire, processes that takes somebody like 15 hours to do. And after like 5 hours of coding, I give them a thing. All they have to do is click a button, right? This has been possible for a long time. Automation engineers have, been around for a while. It's just a little iffy in healthcare for some reason, but AI is becoming a thing, and they're just in such a hurry to implement them.
And I think it's such a mistake because I don't think people are fundamentally, when I say people, what I mean is people who don't really understand like where AI comes from, is that AI is just one big prediction machine. All it's doing is taking a lot of information and saying that this is the most probable outcome that's correct because it's been given so much information that it's able to just predict what might be right, but it doesn't understand what is right. And those are very different things because it can't reason, it can only predict. And if it's given complete authority to try to over somebody's care, it's going to try to predict what's wrong with you, but it's not actually going to see you and then try to reason what's going on with you in the moment.
Yeah. And the more that hospitals try to implement this, the more distrust there will be, because again, these things are not implemented transparently. Like we were talking about transparency earlier.
Yeah, transparency for sure.
Like, okay, they'll tell you, hey, my phone is going to record this and for later. That's very useful, right?
Very useful. Yeah.
But when we start and these systems are being built, the clinical reasoning and all that, this is not something that patients are consenting to. And I think it's highly inappropriate. And so you think that, there is a distrust in medicine. Nurses are trusted, but we're getting to the point where, what I can tell you is you compare the trust that most patients have of the healthcare industry, but then compare it to AI or computers. I would argue that, most people, and I don't have data for this. I'm disclaiming that right now. I can look that up later, that most people would not feel as comfortable with only machinery taking care of them as opposed to a doctor. So even as much distrust as there is, it's still a hell of a lot better than trusting machines to do it. But then we're implementing those machines, right? We're implementing those without permission. That's my problem with things.
Yeah, and I agree with you. And I think that nurses are we're going to have to be like more educated than we ever have been, because we're going to have to try to explain things to people in a way that that they can accept without having to constantly defer to the doctor, have to constantly defer to somebody else, because we're the point of contact for patients. Like that's the reality, and it's almost always going to be the reality, and we need to be able to answer their questions as to the best of our ability, and to develop trust in a way that, like, if I knew that AI was involved in somebody's care, how would I be able to explain that to them in a therapeutic way that would allow them to be at ease, that it's for their benefit and not for their harm, and that if harm did come to them, like, we would be able to take care of it, because doctors, there's a reason why they have malpractice insurance, and that's not because of AI. It's because they accidentally nick an artery. It's because they accidentally operate on the wrong limb. That wasn't AI's fault. That was a person's fault. And so there's always a risk involved in medicine, and AI hopefully helps us narrow the risk. But it also increases the ever present shadow of doubt that patients are having with medicine, and we need to be able to shine a light on that shadow and say, like, no, we are here to help you get better, and this is how we're doing that, and this is how we're approaching that. Because the older generation is only going to continue to flood the ERs and the hospitals, and there will be a time when we won't have to constantly fight that older generation, because eventually, sadly, though, they will pass, and a new generation who's grown up with this technology will be more trusting. But even when but there's still going to be that conversation that's going to have to be had, about transparency, about what we're doing to help you get better, and I don't think that'll ever go away.
And you know what I don't think will ever go away is I think two things will strangely happen at once. One, the role of nursing is not really going to change terribly too much in a certain way. And I'll explain that, because that's a big statement, and that doesn't make sense at first glance, but I've argued this in other podcasts. But nursing will remain what it's supposed to be, which is, okay, we are the most trusted now. The more these things are implemented, the more trust will probably flood onto nurses, because here's what we also are. We aren't just the ones explaining this. We are the last set of human eyes for anything for our patients.
Yeah.
Including post-op, whatever. It doesn't matter. You get all the doctors, CRNA in the world. It is the nurse's ultimate responsibility for the safety of that patient during care, right? And that's because we're the last check. And here's the thing. That's not going to change when AI starts making decisions for doctors, is it? We will still be the last check. We will be the eyes on the patient, and we will be the ones sitting there and saying, hey, all these systems are alarming and saying, we're going to need to do a spinal tap on you, let's say, right? Whatever, right? Weird algorithms can have weird hallucinations. I'm going to go ahead and say that is inappropriate at this time. And I will make sure that does not happen to you until a bunch of people agree that is actually safe. That is the nurse's responsibility now, and it will remain the responsibility of nurse. And I think, if anything, no matter what happens with trust of medicine or AI, nurses are going to be the ones that remain to be the most trusted, because we're going to be like, no. My patient is not going to have their arm taken off. They're here for a gallbladder issue, right? AI system can easily make that decision and make that mistake. And now you would argue, okay, so what if the nurse just goes along with the AI because that's what the tool is for? So then somebody's arm gets taken off for a gallbladder problem. Whose fault is that? It's the nurse's fault. It is still the nurse's fault, because we already have a lot of tools right now, and we have a lot of doctors that are suggesting all these interventions. And you know what? Sometimes it's like, no, that's not safe. This isn't safe. It's our job to do that, right? It's our job to raise the safety concerns and stop things. And only us can walk in a room and say, I don't know what it is, but something's not right with this patient.
Yeah.
Right? Yeah. How many times is that happening? And you could see things before AI sees it, and vice versa. So I just think at the end of the day, what's really, to us, what's the difference between AI proposing all these decisions and a doctor proposing all these decisions, when at the end of the day, we're the ones that are going to be there in the end and kind of do the final check.
I think that whenever there's a new technology that hops on the scene, there's always this massive flood of people who are distrustful. All of the worst fears get manifested in people's minds, and we've seen that. We saw that with the internet. We saw that with computers. We saw that with, I don't know if you recall that there was this massive hacker hysteria when the computers first came out, and saying that, one person with a computer, one hacker with a computer can set off Armageddon, and then eventually that fear died down. It's like, no, a hacker's not going to do that. And I think that we are going to come to the point with AI where it's going to mature, and people are, and its uses will be established. And just like I had surgery on my shoulder recently, and I had 7 different people come into the room saying, "What are we doing? What arm is it? What shoulder is it? Can you tell me what exactly we're doing?" And they marked it. And we're going to have those safety checks. We will get those safety checks, and it is impossible for medicine to be able to clue in every single patient into what systems are changing, what we're implementing, what technology is being used this time around. But I do think that we have to be trepidatious with our implementation of technology, because we can rely on it too much, and we can get stupid and lazy, and we just need to know that, we need to be able to critically think and just use our brains, use your eyes, use your brain, and use AI as a supplement. It's not something to be relied on entirely.
Yeah, the more it's used, the less it's used as a supplement and more for a replacement. I feel like the dumber
Yes,
you are.
we will
and
get dumber.
Because I have to limit my use of it for certain things. You know, there are some things I have used it before in the past for content creation, not for the podcast. But there's still a huge quality difference between what I'm able to do, and I'm not even that talented, and what ChatGPT can do. And I think when you are offloading your thought processes, what makes you think that your thought processes aren't going to atrophy?
They do,
So,
man. They do.
It's kind of like the contact list, dude. Like, you know, now you don't know anybody's number anymore.
Yeah.
And you have like 300 people's phone numbers in your.
Yep. And when you use GPS all the time, you can't remember, directions anymore.
I know. No, I literally can't go anywhere new without GPS. Nowhere. Not around, where we live. It doesn't make sense, but you can go to like a big city and be like, I just go north until it's 29th and then I can go left. And, but yeah.
I've lived here long enough in Washington where I can do that, but I still have a problem.
The city is
weird.
weird.
The interstates,
Yeah, the interstates. I don't know. It's just I don't know how people deliver pizza in 1995. I genuinely don't know. How did you do that?
They had bigger prefrontal cortexes and a far more developed sense of direction.
This episode was a lot of fun. It was nice having a guest on. We've had a couple guests on at this point. If you liked the last couple episodes, please go ahead and follow, share with your friends, leave a comment. If you would like to be on the podcast, whether it be serious or just have some fun, or whether just talk about some things and go back and forth about it, go ahead and leave something in the comments. I used to leave a link in the description to fill out something on Google Forms, but go ahead and share your interests on there. Link to my LinkedIn is going to be in the podcast from here on as well. Thank you so much for listening. Go out there and earn it today.